Welcome. So let me introduce our speakers. The speaker to follow me will be Dr. David Jones, who is Professor of Liver Immunology and Dean of Research at Newcastle University in Newcastle upon Tyne in the UK. To follow Dr. Jones, it'll be Dr. Michael Trauner, who is the Professor of Medicine and Chair, Division of Gastroenterology and Hepatology in the Department of Internal Medicine at the Medical University of Vienna in Vienna, Austria. And to follow Dr. Trauner, Dr. Arun Sanyal, Professor of Medicine in the Division of Gastroenterology, Hepatology, and Nutrition at Virginia Commonwealth University. And Dr. Sanyal is also Executive Director of the Education Core at the Center for Clinical and Translational Research in Richmond, Virginia. So I'd like to welcome my colleagues, and I'll be giving the first presentation. I'm going to first review the topics that we'll be covering to give a flavor of where we'll be headed. PBC, PSC, NASH are really significant causes of liver disease, morbidity, and mortality. Those same diseases impose a significant burden on patients and our healthcare resources. And despite advances in the treatment of these diseases, there remain significant lapses in our therapeutic armamentarium, and there are unmet patient care needs. There's an increasing focus on the role of bile acids, and we'll be discussing tonight the role of nuclear receptors and these agents in their new role as promising agents for therapy for the conditions of PBC, PSC, and NASH. Our understanding of PBC and its therapeutic options have evolved. I'll be discussing some of the original observations of the syndrome of PBC and how our perspective today and the assessment of unmet patient need differs from that with the original description of PBC. And a significant proportion of patients treated for PBC do not respond completely to treatment, the currently available treatment today being ursodeoxycholic acid is the approved treatment. This treatment leaves a significant unmet need that we've been hearing several times throughout the meeting today. Treatment response criteria and also prognostic indicators are important to be able to target the use of our treatments. Looking at PSC, I think that PSC perhaps is one of our most frustrating diseases. There's lack of effective therapy in PSC, and there's a significant unmet patient need. We're going to be discussing the identification of targets that can be appropriately leveraged for developing agents to help control PSC. As regards NASH, there's a striking prevalence of NASH, not only in the U.S., but worldwide. And this really demands that we develop effective therapies to meet that need. We'll be discussing multiple factors, such as insulin resistance, oxidative stress, and abnormal lipid metabolism that can be leveraged to develop effective therapy. So my presentation is going to focus on PBC. We'll be tracing the evolution of PBC, making some comments about how our perspective of that syndrome has changed, and what we've learned in terms of treatment modalities since PBC has been a focus for clinical investigation for decades. I'll then end with pointing out what we still need to know, identifying areas of gaps within our therapeutic armamentarium. So the syndrome of PBC was really first described in 1851 by Addison and Gull. This is a copy of that original report, which really describes a series of patients with chronic cholestasis. And these patients presented with a certain affection of the skin. It's really a report on xanthelasma in patients with chronic cholestasis. And it was accompanied by this hand-drawn colored plate at the end of the article, which really depicts a patient with chronic cholestasis, jaundice, and marked xanthal asthma. And I think that this picture is really a picture that's atypical of our patient with PBC today, but does present the picture of advanced PBC that perhaps was more common in the past. The disease was brought more into the modern age. After 1950, there was another series described by Ahrens, and I think our modern perspective of PBC was first formed following that 1950 article, perhaps during the 1950s, 60s, 70s, and 80s. No effective therapy for PBC was available. The disease was an interesting disease to clinicians. Patients presented with multiple abnormalities and demanded care. After 1987, when ursodeoxycholic acid was reported by Poupon, effective therapy became available and was gradually introduced really throughout the world. As you know, PBC has been recognized as an autoimmune disease, not only because of the immune-mediated markers of elevated immunoglobulin M and mitochondrial antibody, but also because of the multiple autoimmune diseases these patients suffer from, commonly autoimmune thyroid disease and Zika syndrome. The pathogenesis is increasingly being recognized and understood. Currently, it's felt to be an activated lymphocyte attack against biliary epithelial cells, where those epithelial cells have ectopic expression of pyruvate dehydrogenase E2 epitope on the surface of those biliary epithelial cells, leading to cell destruction of intermediate-sized bile ducts with leakage of bile contents in surrounding hepatocytes, inflammation, and then resulting fibrosis, eventually leading to cirrhosis and liver failure. Now, what's changed our perspective, I think, on the condition is that the diagnosis of PBC today has different implications than when it was diagnosed perhaps in 1970 or 1980. There is an increasing prevalence of the disease, perhaps for several reasons. There's comprehensive biochemical testing is common. Patients with abnormal alkaline phosphatase and biochemistries are increasingly recognized. But also importantly is that there are more of us. So in 1980, there were in the United States, in AASLD, there were 250 card-carrying hepatologists. Today, there are 4,000 card-carrying hepatologist members of AASLD. So that I think that then also demonstrates that there's increasing interest and capability in diagnosing patients with PBC in our healthcare system. Treatment is also available, and not only does the treatment perhaps extend life and increase prevalence of the disease, but also is an impetus for the discovery of the disease and diagnosis of patients. The disease is being recognized earlier and earlier. And I'd like to walk through some of the recently recognized observations regarding early PBC. In the past, we thought that the microanatomy of the biliary tree was that the bile canaliculi would anastomose with the canals of hearing, and the canal of hearing was thought to be a portal structure. We now know that the canal of hearing extends out into the parenchyma and the liver lobule, probably about a third of the way out into the hepatic lobule, and there anastomoses with the bile canaliculi. On this photomicrograph on the right-hand panel, you'll see that cytokeratin 19 staining, which is specific for biliary epithelium, identifies intact bile ducts, but also canals of hearing that extend out from the portal tract. A normal healthy portal tract may have 9 or up to 10 canals of hearing extending out from that portal tract. On the right-hand side, demonstrated in PBC, is a canal of hearing expressing HLA-DR antigen. that observation may give credence that the canal of hearing may be immune active and be involved in immune attack. Now, this observation made by Romil Saxena and solidified by Dr. Khan and other members of our group have looked at the number of canals of hearing in patients with very early stage PBC. So patients presenting with a phenotype of PBC, of chronic cholestatic disease, associated autoimmune diseases, undergoing a liver biopsy and showing a lack of canals of hearing in the parenchyma. So loss of canal of hearing may be the first pathologic feature to identify the syndrome of PBC, even before bile duct destruction. And you can see here that bile ducts in this portal tract are completely intact. So this disease has been an interest to many of us for decades. And there are a myriad of clinical trials that have been conducted on multiple agents. Most agents are immune-active agents because of our thought that this disease is an autoimmune, immune-mediated disease. Some of them are not, D-penicillamine being a copper-reducing agent, which is effective in removing copper, but did really not have a beneficial effect. Colchicine, first used widely for alcoholic liver disease by David Kucinich. Several trials were done. Tom Warnes in Europe, Marshall Kaplan and Fenton Schaffner and I did trials with colchicine as an anti-fibrotic agent. Again, the effect of colchicine was far weaker than the effect of ursodeoxycholic acid. And you can see this agent is today the single FDA-approved agent for treatment of patients with PBC. So what is the efficacy of URSO in patients with primary biliary cirrhosis? There's general agreement that this agent will lower alkaline phosphatase and bilirubin values. These data were reviewed in a recent Cochrane analysis. There's also evidence that that URSO can delay histologic progression in patients with PBC, and this is particularly active in patients with earlier stage disease. It reduces the risk of development of esophageal varices, as data that Keith Linder had presented, and it likely improves transplant-free survival, most demonstrable in patients with early stage disease where this drug appears to be most effectively active. Lee and other members of the group at Mount Sinai had reviewed the need for liver transplantation over a 12-year period of time in the U.S. As numbers of transplants in the U.S. increased at a rate of about 250 transplants per year, those patients transplanted for PBC declined by a rate of about 5 to 6 transplants per year. So that this is at the same time that ursodiol was becoming widely used as therapy for PBC throughout the U.S. Corpushow is another author who has analyzed the effect of ursodiol on patients looking at transplant-free survival. Patients with early-stage disease treated with urso and responding to urso have a survival that is similar to the control population of patients without PBC. However, if we look at patients that present with later stage disease, more advanced disease, ursodiol is not effective in moving patients to a life expectancy of the general population, but there is a gap, an unmet need in terms of the efficacy of this agent in improving patient survival. There is also a gap. Let me make a comment on the efficacy of urso. So not all patients will respond to ursodiol, and we'll be assessing the effectiveness of ursodiol later in the symposium. And that gap in efficacy can also be responsible for a diminution in survival. Now, there are treatments that are being looked at. Rituximab, a B-cell depleting agent, Fibrates, PPAR-alpha agonist, obeticholic acid, a farnesoid X receptor agonist, and Nor-ursodeoxycholic acid, which we'll be hearing more about later, in assessing efficacy, in assessing new treatment opportunities for patients with PBC. I'll briefly comment on some of these. So Rituximab was the subject of a small study of 6 patients, an open-label study, showing immune suppression, as would be expected with fall in immunoglobulin levels, as well as mitochondrial antibody titers, and improvement in alkaline phosphatase, at least for the beginning period of observation at week 36. Alkaline phosphatase levels tended to rise later in the period of observation. Fibrates have been used and are currently under investigation in this syndrome. So fenofibrate is a PPAR-alpha agonist, a fibric acid derivative. It's a drug that's been around for some time. We're commonly aware of this agent used to control hyperlipidemia. This agent can alter immune regulation and also can affect cell proliferation. The PPAR-alpha activity, this receptor binding activity, can also have a role in regulating bile acid synthesis and detoxification, modulates phospholipid secretion, which can also help protect biliary epithelium. Fibrates can be cautioned for use. The package insert for fibrate cautions that there's a contraindication for its use in active liver disease and PBC, so that utilization of this agent would require further investigation in terms of defining efficacy, as well as a focused population to be able to assess its risk-benefit ratio. A study was done by Cynthia Levy, and this is was a 20-patient study, an open-label study, looking at fibrate use with alkaline phosphatase levels being the endpoint. These patients were on ursodiol, had an incomplete response to ursodiol. Fibrate was added, and alkaline phosphatase levels significantly fell. When the fibrate was discontinued, the alkaline phosphatase levels again rose, as might be expected. Now, one of the main concepts that I'd like to engage you in this evening is really thinking about bile acids differently than we might have 15 years ago. So when I was in medical school, bile acids were considered detergents. They were to help solubilize bile, help with fat absorption and dispersion in the gut, and to improve fat absorption. Our concept of the utility of bile acids in biology has now shifted to them being receptor ligands, and looking at that role of a bile acid as a modulator of homeostasis. So one of the agents that we're going to be discussing is obeticholic acid. This bile acid binds to the farnesoid X receptor, which is a nuclear receptor. This nuclear receptor can be thought of as an intracellular, intrahepatocyte sensor for the level of intracellular bile acids. The farnesoid receptor is bound by obeticholic acid. The normal ligand for the FXR receptor is chenodeoxycholic acid. Obeticholic acid is structurally similar to chenodeoxycholic acid and has a very high affinity for the farnesoid X receptor, and is also very specific, binding to that particular receptor. In that position, as an agonist for the FXR receptor, there's decreased bile secretion, decreased hepatocyte uptake and transport of bile acids, and regulation of bile acid conjugation and excretion, so that intracellular sensor is ideally positioned to control the features of bile acid metabolism and cholestasis. Now, this receptor not only is central to bile acid homeostasis, but also has multiple other metabolic activities. It can decrease hepatocyte triglyceride production and storage. It has an impact on hepatocyte regeneration, as well as intestinal bacterial overgrowth and protect against bacterial translocation. It may modify other features such as insulin sensitivity and adiposity, and also have a role as an anti-inflammatory agent and consequent anti-fibrotic agent. So that the myriad of activities we'll be further discussing tonight, but this agent seems to be ideally poised for addressing some of the features of chronic cholestatic disease. I'd like to review two studies that have been done, two clinical trials. The first is in patients with PBC who were on ursodiol but had elevated levels of alkaline phosphatase, so incomplete responders to ursodiol. Obeticholic acid was given at 3 different dosage levels and compared to a placebo control population in the study. The treatment period was for a period of 12 weeks. And I'll show you the alkaline phosphatase data. There were similar data for aminotransferase, alanine aminotransferase activity. But alkaline phosphatase levels fell significantly during the first month of obeticholic acid administration. There was a decline of about 25% from baseline for alkaline phosphatase values that persisted during drug administration. The adverse event that was seen during the trial was pruritus, which was largely seen in patients with higher doses of drug. So if you noticed on the efficacy slide, all 3 doses that were tested had similar levels of efficacy in improving biochemical values. These observations of pruritus at higher doses of drug has led to further evaluation of lower dose obeticholic acid in future studies. There was a study of monotherapy in patients with PBC. Again, 2 doses of drug of obeticholic acid were compared to placebo. And if you notice, the alkaline phosphatase values on the left-hand axis are higher than the values that were seen in the prior study, perhaps a reflection that no Nor-ursodeoxycholic acid was present in this protocol. This was a monotherapy study with obeticholic acid. And again, there's a dramatic fall in biochemical values on drug. So in patients who are on ursodeoxycholic acid, there is an unmet need. Most patients on urso continue to have abnormal alkaline phosphatase values. About 40%, and depending upon the endpoint that's chosen, about 40% of patients on ursodiol will be considered non-responders or partial responders. Histology, liver injury, in patients with an incomplete response to urso, or patients with a more advanced disease, the stage 3 or 4 patients with PBC, progresses. Patients with elevated bilirubin, male gender, and also those patients presenting at an earlier age seem to be at high risk for non-response or partial response to ursodiol. So these populations of patients present really an unmet need and stimulate us to look for further opportunities for therapy to meet patients in those categories. Thank you very much. Now I'd like to ask Dr. David Jones to come up and follow my presentation.
Thank you. It's a real pleasure to be able to talk about an area of great interest for me, which is PBC, and to really develop the ideas about where there is unmet need in this disease. And you've heard about URSO and the effectiveness of that drug. It's the licensed therapy in PBC. And I'll just take a step back and ask the question, is there unmet clinical need? And the answer is, I think there are 2 areas where there is a real problem. Now, the first of these is, this is some data from the UK, a cohort we've been following up now for 12 or 13 years. And this is real life. This isn't a trial. These are all our patients living in a certain postal code area of Newcastle. And they're matched against age and sex match controls from the GP register. These are real PBC patients in the era of effective therapy with URSO versus controls. And as you can see, PBC patients still have a significantly impaired survival compared to controls. So for whatever reason, in an era where we have URSO available, patients still die at too high a rate with PBC. So there is an unmet need somewhere to do with that. So if patients aren't doing as well as we would expect them to do with controls, why might that be? Where's the problem? Well, it could be at various different levels. It could be that the drugs aren't as effective as we think they are, or that our biomarkers of response don't accurately predict real response. It could be that the effectiveness is not as universal as we think it is. There may be people who don't respond. It could be the drugs are effective, but we aren't using them optimally. It could be that the drugs are effective, but aren't actually getting into people. Or it could be some combination of the above. And in trying to work through how we deal with this in practice, I just want to go through some of the bottom points first, because I think there are some real issues there and some important take-home messages. This is the first slide which introduces the UK-PBC cohort. This is a thing that my colleague and I have been working on for a number of years now. And we have recruited now a cohort of over 5,000 patients in the UK with PBC, currently about a third of all patients in the UK. And it's a truly unique resource that allows us to look at a national snapshot of disease. We've recruited from patients from every hospital in the UK. So this is a genuine representative survey of a national cohort of patients. And when you look at that cohort, we find that 20% of patients are not actually being treated with URSO at all. There is a significant percentage of patients who are being treated with doses of URSO in the 10 to 12 milligrams per kilogram range. That's below the optimal dose, or even lower than that. There are some issues with adherence to therapy, concerns about weight gain, nausea, and hair loss. If patients don't take the treatment because they're worried about it, it's not going to work. And I think we need to have, bearing in mind the data we have about URSO and some of the things I'll show you later, a really simple and consistent message about URSO. Use URSO universally as first-line therapy. It is the building block of what we do. And no surprise, one of the things we're now doing in the UK is getting that figure of 80% usage of URSO up to above 95%. It is the key first step in everything we're doing. So this is an image that you'll have seen before in Keith's talk this afternoon, and this is the summary of the original URSO trials. And when you look at this, this is the evidence that URSO is effective. And this is URSO versus placebo for 2 years, and then the placebo patients were often converted over to URSO in the studies. And this is what led to the licensing of URSO, and this is what shows that the drug is effective. But an image like this hides something very important, which is that different patients respond to this drug in different ways. It is not a universal factor. And in patients who are receiving URSO, it is this variability in response which is absolutely critical, and it is fundamental for where we go next in terms of developing therapy. And I think one of the key take-home messages today is that you have to look at your patients with PBC not as a uniform group of people, all of whom are having a therapy which is broadly effective. It is this very black and white response versus non-response in patients. You need to be thinking about your patients. Are they responders to this drug or are they not? So the concept of response came out of work from these original cohorts where the investigators looked at subgroups within those cohorts who did well and who did badly. And there are a number of studies that have looked at different criteria, and this is one of the problem areas. So this is one of the first studies which identified a subgroup of people with these criteria. If you, at the end of a year's treatment at 13 to 50 milligrams per kilogram of URSO, had a bilirubin that was less than 1 times the upper limit normal, ALT less than 2, and ALK Phos less than 3 times the upper limit of normal, what you had was a 96% survival versus 99% of the control population. This group of people essentially had a normal lifespan. So if you met those criteria, you did very well. But in contrast, if you didn't meet those criteria, you had a 69% survival, which was actually identical to the Mayo score predicted survival in the absence of treatment. So there is a group that does well, and there is a group that does badly. Now, as I said, there are different versions of these criteria developed in different populations, and another one that you'll hear about are the Barcelona criteria, and this is a dynamic criterion. This is a 40% or more decrease in alkaline phosphatase over the course of that year's therapy or a normalization. Now, one of the issues with all of these studies developing criteria is that they all worked really well in the population in which they're derived. Of course they did. They were designed to fit those populations, but they didn't really reciprocate very well. They all included a problem of virtual controls. It's normative data for the population. I call it the 65-year-old woman paradox. If you live to be 65 as a woman in Western populations, then actually your survival after that point is very good indeed. So the control data may have overestimated survival. And if you looked at the UK data, one of the things that's important is that they're real live controls rather than this normative population data. So this leads to a question of generalizability, and there's a broad question about the fact they all dichotomize what's a continuous variable. If you just don't meet the criteria, you're clearly very different to somebody who has normalized their liver blood test. We've got to be able to deal with that as we move forward. But these are the studies that introduce the concept of URSO response. And as I said, it's really critical for how we move forward in this disease and what we start to do about people who have still got problems. There's also a very important issue with it. These were the first go at it, and these populations did tend to include a number of patients with advanced disease. And of course, in your clinical practice, the majority of people will have early disease. And these are not the optimal criteria for the large proportion of patients that you see. And there is an evolution of the PARIS criteria, which are called now PARIS 1. These are the evolved criteria, which are called PARIS 2. And these are specific for patients who are not cirrhotic. And the criteria in this group that are optimal for survival is an ALT and an alkaline phosphatase, both at less than 1.5 times the upper limit of normal after medical therapy for a year. So URSO, 13 to 15 milligrams a kilogram for a year. And these are the only criteria which are actually significant in these early stage patients. So ALT and ALK phos less than 1.5 times the upper limit of normal are the best proven ones. And if you look at those criteria, what you see is 53% of these young patients respond, and the adverse outcome in responders was 5%, so virtually no adverse outcomes, and 16% in the non-responders. So they really are the criteria that currently seem to work best of all in these patients with early disease. One of the questions, a philosophical thing, he's saying, why is he worrying about 1.5 times the upper limit of normal or 3 times the alkaline phosphatase? Why don't we cut to the chase? Why don't we look for normal liver function tests after you've treated people? I mean, normal is normal is normal. And so I just show this because I think it's this one study that addresses this. When they developed the PARIS 2 criteria, they looked at some variants of this. One of these were PARIS 2C, and these criteria are in fact normal LFTs at the end of therapy. And what you can see is that if you meet those criteria and are a responder, therefore, at the end of long-term follow-up, you have a 0% mortality. So absolutely, if you have normal LFTs with PBC, you do not have any additional mortality over and above controls, with 16% of non-responders getting an adverse effect. The point, however, is that only 28% of this group of people actually were responders. So these criteria are probably a bit too tight, although it's quite an elegant idea that we should strive for normality, and as I said, it certainly is associated with a really good outcome. So probably normality is a bit too much, and we need to be looking at criteria along the lines of the PARIS 2, 1.5 times the upper limit of normal for ALT and alkaline phosphatase, something in that region. I said there was a major issue with reciprocity and the fact that these were all derived in one population and then they didn't validate quite so well in other. And if you in fact take all of the populations in which all of the criteria were added together, in fact we've now done the UK study and our population size is bigger than all of those studies put together. So we've done something which I think really puts this whole argument to bed. And this is work from George Mells, my colleague who's in the audience. And this is the UK validation of all of the response criteria. And this data is on 1,300 patients, so a very large cohort, part of the UK population. And the important thing is that none of the criteria are actually developed in this population. It's completely independent validation. And what you can see over here, really for each of the Barcelona criteria, Paris 1 and 2, and the Toronto criteria, another criteria set I haven't really talked about, what you see in blue is the survival in responders compared to red, which is the non-responders. This is prospective follow-up in a very large cohort, and these are all highly significant. So this puts the argument about URSO response and non-response to bed. This is the whole issue when it comes to thinking about URSO. If you are a responder, to these criteria, and as I say, the PARIS-2 are the ones that probably work best for young patients. It absolutely predicts what happens to people, and so you need to be aware of your patients who are non-responders and be thinking about what you do next with them. This is some unpublished work which I think is really important, and this takes the whole argument a step further. Is there anything else in PBC that predicts outcome other than response to URSO? And down here, this is the key one, the multivariate analysis using a time-to-event analysis with both baseline characteristics before people were treated and also response to URSO at a year. And if you look at this, what are the factors that predict outcome in totality in PBC patients? It is only two things. It is response to URSO down here, and it is a series of criteria up there, sodium, platelet count, bilirubin, which of course are all features of advanced disease. So what predicts outcome in PBC patients treated with URSO? It is whether you respond to URSO at the end of a year and whether you were cirrhotic to start with. It's as simple as that. And obviously you can't do anything about being cirrhotic if you're cirrhotic, so everything is about getting people into this response status. Now, this is a little thought experiment, and I think there is a bit of an elephant in the room here, which is that, of course, a lot of people meet URSO response criteria before they're even treated with URSO. And let's have a little think about what that actually means in practice. So remember, it's about being less than 1.5 times the upper limit of normal at the end of therapy. But what happens if you meet those criteria before you're treated? So this is, again, the UK-PBC data. So 80%, just under 80% of patients are URSO responsive using the PARIS-1 criteria. So that gives you just under 1,000 beneficiaries of URSO per 1,000 patients in the UK-PBC cohort. And by any criteria, that suggests that URSO is highly effective. But how does this change when you factor in the fact that people meet the criteria before they're treated and therefore philosophically aren't going to be benefiting because you can't go into that low-risk category if you're there to start with? Well, this is what happens. So remember in 1,000 patients, remember 20% aren't treated. So actually in that 1,000 there are 200 untreated patients. We can do something about that. But in the 800 patients who are treated, 80% will respond. Those are the UK figures. So that gives you 640 responders and 160 non-responders out of your 1,000. But of those 640, 74% met the criteria before they were even treated with URSO. So this gives you, therefore, 474 pre-responders who probably are getting relatively little benefit from PBC. So if you then do the maths, what you find is that in your 1,000 patients, there are 160 non-responders and 166 true responders, people who've gone from being a non-response state to a response state. So therefore, for every 100 genuine responders to URSO, there are 96 genuine non-responders. So URSO is highly effective in PBC, but actually there is probably as large a group of people out there who don't respond to it as who do respond to it. And that is the unmet clinical need in terms of risk. So what do we know about these non-responders? And again, this is the UK-PBC data, and this shows you the value of these big national cohorts. There is also the World PBC Study Group, which has similar data, and these are multi-thousand patient cohorts, which have really allowed us to look at these subgroups who are really clinically important. And what you see with this is that age at presentation is directly associated with risk of non-response. The younger you are at presentation, the less likely you are to respond to URSO. And of course, the more years you need out of your liver. And there's a really important figure. This is what we call treatment failure. This is patients who are either in a state of URSO non-response right now or already been transplanted. And if you look at this group presenting below the age of 50, 50% of those people are either already transplanted or non-responders. 50 at 50, that is a big unmet clinical need. And this is why we're still transplanting people with PBC. They are patients presenting young on URSO who fail to respond. This is the unmet clinical need. There's another interesting observation about non-response. Dr. Bodenheider hinted at this, that there is a gender effect, that men overall are less likely to respond to URSO, but men don't have the age effect that women do. So men seem to have a different biology and a different kinetic. And of course, if you look at the point at which those intersect, it's around about 45. And we do just wonder if there may be some endocrine factor, some hormonal effect in terms of URSO responsivity. I think it's a really interesting question. And the other factor about response is if you look at the criteria by which people fail. These are the PARIS-1 criteria, so they include ALT, bilirubin, and alkaline phosphatase. The younger you are at diagnosis and treatment with URSO, the more likely it is that you don't respond by ALT criteria. The elderly people, it's all alkaline phosphatase and bilirubin, but younger patients, it's ALT. It does seem to be biologically quite a different disease in these young non-responding patients. So we're starting to understand the biology of non-response, which will have an important impact for treatment. So, we've heard PBC is an autoimmune disease. You get autoreactivity, it damages the bile ducts. That gives a bile retention effect with hydrophobic bile acids. That causes a cycle of further bile duct injury, followed eventually by fibrosis. And those are the stages of the disease process. So why might you not respond to treatment? Well, it could be that you have a more immune response to start with. It could be that you have a more toxic bile pool, more hydrophobic bile acids. It could be that your biliary epithelial cells don't cope as well with injury as in other people. Or it could be, as we've shown before, that people are just cirrhotic by the time they start their URSO treatment and it's less effective. Unpicking this is very important because actually the treatments that you would give would be quite different in different settings. And if we mismatch the treatment to the stage of the disease process, we're going to have disappointing results. So if it is a hyperimmune response, then this may be where targeted immunosuppression, biologicals and things comes in. If it is about more toxic bile, this is where the second-line bile acid therapies come in, like obeticholic acid, and I think this is a key area. There are biliary epithelial protectant agents probably coming along if it's a difference in the response of the biliary epithelium. And of course, if it's pre-existing fibrosis and cirrhosis, anti-fibrotics might be effective, but the answer to that, of course, is earlier diagnosis and earlier treatment. So there is an awareness element in this. It goes back to early diagnosis, treating everybody with URSO and taking it from there. FXR agonists have been introduced, and I'm quite simple when I look at this. What FXR agonists like obeticholic acid do with a bile acid base is they have a number of characteristics they share with us, so like choleresis, anti-apoptotic effect, antioxidant, but they have some additional direct properties when they get into the liver. They induce bile acid detoxification, induce bile acid conjugation, suppress bile acid synthesis, and they alter bile acid transport. So they have additional actions in the liver directed at the bile. But there is also a very interesting thought here that there are indirect properties because these agents actually work in the gut and stimulate the release of FGF19, which then goes through into the liver, which has effects there. And it may well be that another important difference between obeticholic acid and URSO is that it can exert effects without getting into the bile pool. So it could be that URSO non-response addressed by OCA is by a manifestation of these indirect actions. So I think this will unfold shortly. You've seen this data. This is the phase 2 trial data for obeticholic acid, just shown in a slightly different way in terms of this really important concept of URSO response and non-response. So if you take URSO non-responders and give them obeticholic acid, then what you see is 70% of patients in the 10 milligram dose convert into an URSO response state. So you've taken a very big chunk out of the numbers of patients who are URSO non-responders. Interestingly, higher dose was less effective, and this is really important because the 10 milligram dose is the dose that didn't give pruritus. And the phase 3 trial focuses around these lower doses. So you actually have the sweet spot for therapy around 10 milligrams, which is going to be, I think, much more effective and much less associated with side effects. So, there is a challenge with all of this, and that's how do you design trials in PBC, and I think this is something we all need to face up to because we need to get these drugs out there. I'm talking about 40 to 50-year-old patients with very aggressive disease where we need to do something for them. We need to define the at-risk population requiring second-line therapy. I think we're making some real progress with that. We need to work out outcome measures. Do URSO response criteria apply to other therapies? That's a very live issue with the FDA at the moment. We have a lack of relevant biomarkers. Those need to be developed. We have the impossibility of carrying out hard endpoint trials due to prolonged disease, and are there other markers that we could use like FibroScan, which is available in Europe, to be able to look at that. And of course there's the difficulty in performing a histology-based trial, the acceptability of biopsy, the risk of biopsy, and the lack of effective scoring systems. So the advent of what seem to be biologically very plausible therapies with real benefits, we need to think about these issues. I said to you that there were 2 unmet clinical needs, and I think just 2 slides on the second one because I think it's really important. We're talking here about treating the disease better and avoiding transplant and so on and so forth. But remember, there is also a big burden of symptoms for patients, and don't forget that. 2 major factors, fatigue and pruritus, and they can lead to significant impairment of quality of life. 35% of PBC patients in the UK study report poor quality of life compared to only 6% of age and sex matched controls. 46% of patients rated their perceived health status as fair or poor compared to only 15% of the healthy controls. And in terms of change over time, 49% of the patients reported their health as worse compared with the previous year. These symptoms really matter to patients, and as well as looking at biochemical and other endpoints that really matter to hepatologists, we have to look at these symptoms as well. And just going into fatigue a little bit more, and these are very large data sets, over 2,000 patients. Fatigue is an important symptom with significant impact on patients, with the greatest impact on perceived quality of life when it's accompanied by social dysfunction symptoms. These are socially isolated patients who feel their symptoms. It's really important to remember that. The critical issue is how patients adapt and cope with fatigue, as this will ultimately impact their quality of life. So be positive with them about their fatigue, engage with it, and help them understand it. And disease management should ultimately target both the underlying biology of the disease. Of course, we want to stop people needing transplants or dying, but we also need to target symptoms because quality of life matters. So, what's the bottom line for PBC in 2013? Urso is safe, it is relatively cheap, provides clear benefit, it should be used universally, the debate is over. An important minority of patients, and it's a significant minority, respond incompletely and are at significantly increased risk of death or need of transplant, and they are typically younger patients, frequently with young families. That's where the unmet need is. Best practice to identify non-responders and triage them for enhanced surveillance and consideration for trials. I think people should be going forward into trials until drugs are licensed for second-line therapy, and I would suggest to you need to go out into your practice and triage your patients. Work out who is low risk, work out who is high risk, and monitor them appropriately, and then move forward for therapy. Endpoints are a major challenge in second-line therapy evaluation. We need to work as a community to solve those, and don't forget symptoms. They remain a major clinical challenge and an important endpoint for evolving therapies. So, unmet need of risk of the disease, we need better treatments, unmet need with symptoms. Thank you very much.
Our next speaker is Dr. Michael Trauner. He'll be speaking on medical management of PSC, evolving solutions to ongoing challenges.
Thank you very much, Henry. Thank you very much for the invitation. It's a true pleasure to discuss the management of PSC with you. PSC is really a deadly disease. It affects patients who present in young adult age with a median transplant-free survival of 12 years, 10-year survival of 65%. So there's really something which we have to do about that disease. So how can we define PSC? PSC is a fibro-obliterative disease of the large and of the small bile ducts, which leads to strictures and dilatations, which you can see on the cholangiograms. And also nowadays, the diagnosis is no longer made via ESCP, but via magnetic resonance cholangiography, where you really can see those strictures and dilatations. In addition, patients also have this fibrosis, this concentric fibrosis around the small bile ducts, and actually 5 to 10% of patients only have small duct PSC. This disease has a better prognosis. Nowadays, it's considered an early stage of large duct PSC because patients progress to large duct PSC in about 20% over the period of 10 years. In order to make the diagnosis of small duct PSC, you still need liver biopsy. Otherwise, there's only a role for liver biopsy to exclude overlap with other diseases such as autoimmune hepatitis. Typical is the association with inflammatory bowel disease, with about 70 to 80% prevalence of colitis in patients with PSC. There are several pathogenetic concepts involved with that, such as translocation of bacterial products, of endotoxin, translocation of gut-primed T lymphocytes to the liver, and we'll talk about that a little bit later. What is really important is that the endoscopic and the clinical appearance of IBD in PSC is notoriously mild. It's also shown on this image. The patients actually have some more activity on histology, but endoscopically the disease is mild. Also clinically, it is oligo or even asymptomatic due to rectal sparing. The patient has right-sided dominance of the disease. There's a higher prevalence of backwash ileitis. And coming with that, and that's clinically really relevant, is even more increased risk of colorectal cancer than we already see in ulcerative colitis. So it's absolutely critical to screen these patients with colonoscopy for existence of PSC IBD. What are the ongoing challenges in the medical management of PSC? Well, first of all, it's the early and the correct diagnosis of PSC, and certainly good quality imaging, good MR cholangiography, a good collaboration with the radiologist is essential. But it's also important to exclude secondary causes which are potentially treatable, to exclude IgG4-related disease, which would challenge or which would call for a therapeutic trial with steroids. Very likely the disease which we nowadays classify as PSC is in reality a mixed bag, and there may be several prognostic subgroups which we are going to see to disintegrate into several entities. And actually the separation of IgG4 related disease from classic PSC is a perfect example for that. A very important challenge is the malignancy risk, so we have to surveillance the patients for colorectal cancer due to PSC IBD, and most importantly for cholangiocellular carcinoma with a lifetime risk of about 10 to 15%. So it's important to keep in mind that PSC is a pre-malignant condition, and that about 50% of deaths in the age of liver transplantation, where we can rescue the patients from end-stage liver disease, are actually due to cancer. A major challenge is, of course, the limited therapeutic options. We have a lack of established medical therapy. We are stuck with endoscopic therapy of dominant stenosis, which can occur in about 50% of cases, where we can dilate them. We can do short-term stenting, but there's also some controversy about that. And the only really established treatment is liver transplantation for end-stage liver disease, which really produces good results. So what can we learn from the pathogenesis of PSC for the management of our patients? And I think it's fair to say that many of the shortcomings in managing these diseases comes from our poor understanding of the pathogenesis. PSC is generally considered an immune-mediated disease. However, immunosuppressive attempts, including anti-TNF strategy, are notoriously ineffective. The only exception is IgG4-related disease or overlap with autoimmune hepatitis, where immunosuppressive therapy works. There are gut-derived factors which may play a role, such as translocation of endotoxin or lymphocytes. However, there is no firm correlation with IBD activity. There even seems to be a paradox inverse correlation with IBD activity, meaning that the patients undergoing liver transplantation very often have very mild IBD, which however can aggravate after liver transplantation. And regarding the recurrence of PSC after liver transplant, actually the presence of an inflamed colon is critical, and colectomy protects against recurrent PSC. One strategy actually targeting that may be antibiotics, which also target the microbiome, or other factors which may translocate from the gut. And there may be a role of new biologicals. So far, all strategies targeting inflammatory bowel disease or similar inflammatory processes which occur in the gut and in the liver have been ineffective. There may be a role for ischemia, especially the obliteration of the peribiliary plexus may play a role during the course of the disease. And you are well aware that ischemic cholangitis is an important differential diagnosis of PSC. And finally, there also may be a role for abnormal bile composition and biliary toxicity, which we try to target with bile acid-directed therapies. However, here, ursodeoxycholic acid, in contrast to the advances which we've seen in the management of PBC, in PSC has been disappointing. And there are novel bile acid-based therapies which may bring new progress. But what is the current status of bile acid-based therapeutics in PSC? Urso, as traditional bile acid-based therapy, is ineffective in PSC. The role in slowing disease progression is unclear. The low dose is safe, but the efficacy has not been proven in several randomized controlled trials of increasing doses, and actually you have a detailed listing of the URSO saga in your handout showing that all these trials did not show a survival benefit. Even high-dose URSO is harmful, and actually the Mayo Clinic trial with this was prematurely stopped. There's also limited information to support URSO as a chemopreventive drug to prevent cholangiocellular cancer and colorectal cancer. And also here we have a high-dose risk, meaning that high doses actually may even lead to increased risk of colonic dysplasia. Therefore, the AASLD guidelines advise against the use of URSO in PSC, whereas the EASL guidelines are more open, actually leaving some space for the use of URSO, especially in early stage disease, where the hope is that the biochemical improvement, which we often see in these patients, actually might translate into some survival benefit. The hope is that we have novel bile acid-based therapies on the horizon. Actually, we have two modified bile acids. One is a modified ursodeoxycholic acid called Nor-urso, and a modified chenodeoxycholic acid called obeticholic acid, which you already have heard about in the two previous talks. So what is Nor-ursodeoxycholic acid? Nor-ursodeoxycholic acid is actually a side chain, a shortened derivative of ursodeoxycholic acid lacking one methylene group. And this side chain shortening actually results in resistance to conjugation with glycine and taurine. And here it is very important to keep in mind that normally bile acids in the body are conjugated with glycine and taurine. So it's a major change of bile acid biology when you interfere with conjugation. And this Nor-ursodeoxycholic acid was tested in preclinical models of sclerosing cholangitis. A very good model for that is the MDR2 knockout mouse, which develops the typical sclerosing cholangitis features on cholangiograms and the onion skin type fibrosis of the bile ducts, which you see here in this larger magnification. Actually, when knockout mice with the sclerosing cholangitis, and you can see that here you have this massive concentric fibrosis compared to a normal bile duct in a wild-type animal, Nor-urso was actually able to virtually restore the phenotype to the degree like we see it in the wild-type animals. Urso was of some efficacy. It actually also improved a little bit the histology. However, biochemically, it aggravated the disease. So what is the reason that Nor-urso is so much better than urso in curing the phenotype in these knockout mouse animals? Actually, the explanation for that is the resistance to conjugation. And this resistance to conjugation results in a colohepatic shunting between the hepatocytes and the bile duct epithelium. And this is colohepatic shunting. This is not the normal enterohepatic cycle via the intestine, so it's a kind of shortcut within the liver. And this has two major consequences. First of all, there's a dramatic enrichment of this bile acid within the liver as a result of the colohepatic shunting. And the second important consequence is that this results in the generation of bicarbonate. And bicarbonate protects the bile duct epithelium from bile acid toxicity by reinforcing the bicarbonate umbrella. In addition, Nor-urso also has important anti-inflammatory, anti-fibrotic, anti-proliferative effects, and also detoxifies bile acids, which then become eliminated via the urine. So these very promising properties of Nor-urso led to the clinical development of this compound, which currently is undergoing phase 2 trials, and there's a large multi-center European trial involving more than 30 centers with that, and we are all very excited to see what this compound is showing clinically. In addition to Nor-urso, we also have the opportunity to target the bile acid receptors, and you already have heard about one of them, the nuclear bile acid receptor FXR. There's also a second plasma membrane-bound receptor, a G protein-coupled receptor, which is called TGF5. I have to emphasize at this point that Nor-urso and also urso are no ligand for these two receptors. And actually, the interesting finding is that SNPs of TGF-5 have been found in PSC and ulcerative colitis. So there's really a strong support to use TGF-5 ligands or test TGF-5 ligands in PSC. And actually, now we have compounds available to target these two receptors, both TGF-5 and FXR. And again, this was tested in the MDR2 knockout mouse model of sclerosing cholangitis, where mice were treated for 1 month. So basically the same setup as I've shown you with Nor-urso. And actually 3 compounds were tested. One is obeticholic acid, which is an FXR ligand. You've heard about that. That's already in clinical development for PBC, and this is the first preclinical PSC model where this compound was tested. There was a TGF-5 ligand and actually also a dual ligand. And actually, the interesting finding was that only the dual ligand was able to cure the disease. Actually, here again, you have restoration of the biliary fibrosis to a level which you see in wild-type animals. Here on the left are the untreated animals, and the other 2 compounds actually were not effective in the model of sclerosing cholangitis. Actually, to cut the long story short, also the dual ligand acted exclusively through the nuclear bile acid receptor FXR. And this slide is actually summarizing how FXR ligands may protect the bile duct in PSC and perhaps also in other cholangiopathies. Actually, by stimulating FXR, you get a suppression of bile salt synthesis and thereby lower the bile salt load to the bile duct epithelium. There's a stimulation of phospholipid secretion, and also, and this was really surprising to see, a stimulation of bicarbonate secretion. So reinforcement of this bicarbonate umbrella seems to be a very important therapeutic principle in healing the duct. And even if you do not know what basically the underlying disease is or the underlying pathogenesis is, and this is the case in both PSC and probably also in PBC, it helps to cure the duct by helping to handle bile acid toxicity, which is reduced by repressing bile acid synthesis and promoting phospholipid and bicarbonate secretion. And actually also other compounds may share some but not all of these features. Urso definitely is also diluting the toxic bile acid pool. Urso also has been shown to promote phospholipid and bicarbonate secretion to a certain degree. And similar may apply to fibrates and even budesonide, which we think of as a immunosuppressive, actually may work mainly through reinforcing the bicarbonate umbrella. And there are some encouraging data in PBC, but so far not in PSC. This slide is summarizing the potential of nuclear receptor agonists in PSC, and actually many of the compounds which I've shown you in the previous slides, in addition to FXR, are nuclear receptor ligands. And here on the left we have the different nuclear receptors listed. We have FXR, PPAR-alpha, PPAR-gamma, the vitamin D receptor, and the retinoic acid receptor. We have various therapeutic ligands for that. We have obeticholic acid, which is the FXR ligand, or the 767 compounds, fibrates, and also DHA, which, for example, has been used in PSC and in cystic fibrosis, probably act via stimulating PPAR-alpha. PPAR-gamma can be activated through glitazones, which now have not been tested in PSC models, but actually, interestingly, curcumin, the yellow pigment of curry, actually is activating PPAR-gamma. Vitamin D, of course, and the retinoic acid are additional ligands. And all of these compounds work via very similar mechanisms by interfering with bile acid homeostasis, by having anti-inflammatory and anti-fibrotic activities. All of them have been tested preclinically in various models, mainly the MDR2 model, and there are very little clinical data, so I really want to emphasize that there's no data supporting the use of these compounds currently clinically. With FXR ligands, you are aware, and you've heard in the two previous talks about the clinical development in PBC. There may be also a phase 2 trial planned in PSC, but there are no data yet. And with Fibrates, there are only single case and small series with PPAR-a ligands in PSC, which have shown some benefit. And you've heard in Henry Bodenheimer's talk about the potential concerns about the use in cholangiopathies. So to put this really into context, what could be the place of these various ligands in the treatment of cholangiopathies? And I want to summarize both PBC and PSC. For PBC, we've heard it's pretty clear. We have URSO as an effective drug. We have FXR for non-responders and maybe other compounds. For PSC, it's much more open. We think that Nor-urso could be a promising compound, but certainly FXR ligands are extremely interesting because with FXR ligands, we may be able to target also the gut. And I think this is something which we have neglected as hepatologists in the past, because the gut, of course, is a very important prognostic factor. IBD is silent, but colorectal cancer is not. So with FXR ligands, we are able to both target inflammation and possibly also carcinogenesis in the gut. And the common denominator of that actually may be the gut microbiome, which also may be a driving factor for the disease as well. So the interesting concept behind that could be that nuclear receptors such as FXR could be a one-stop treatment of PSC and associated inflammatory bowel disease. What other novel therapies are in the pipeline? Certainly the gut microbiome is of key interest. Antibiotics have been used. Antibiotics, of course, are recommended to cover during endoscopic therapy for prophylaxis or to treat bacterial cholangitis. But antibiotics also have been used to treat PSC in small trials with small patient numbers. So far, there are only limited data showing some biochemical improvement with absorbable antibiotics such as minocycline and metronidazole. There may be a greater potential for the non-absorbable antibiotics such as vancomycin or also rifaximin, which could modify the gut microbiome. Of course, we also have to be aware that antibiotics also have immune modulatory effects. So the mechanism behind that may be complex. There is potential for other gut-focused therapies. Immunosuppressants so far have been disappointing, including TNF strategy, but there may be room for new biologicals targeting lymphocyte homing, such as gut-specific alpha-4 beta-7 integrins, such as vedolizumab, or Janus or tyrosine kinase inhibitors, which have been successfully tested in ulcerative colitis, and also maybe anti-fibrotic. And certainly, anti-fibrotic strategies such as targeting lysyl oxidase, homolog 2, simtuzumab, which is currently undergoing development for liver cirrhosis, NASH, you will hear about that, and also PSC is of interest because PSC is a fibro-obliterative fibrotic disease. So where do we stand in 2013 with treatment of PSC? Unfortunately, I have to leave you also at the end that there is no established medical therapy. Most European centers and also some centers in the US still would use URSO at low to medium doses and, of course, avoid high doses. Endoscopic therapy of dominant strictures is also typically combined with giving URSO, and we have to be aware that at least retrospective analysis suggests that this dual approach actually may be able to prolong survival. So far, liver transplantation for end-stage liver disease and the other indications listed here is the only established treatment. There is no real strong data to recommend URSO for chemoprevention of colorectal and cholangiocellular cancer. So we are basically left with surveillance, colonoscopies for cholangiocellular cancer. This is less well worked out, but most of us would do annual MR scans and determine tumor markers. Basically, when we bring this into a traffic light scheme and see what are we really allowed to do, actually the traffic light is green only for endoscopic therapy and for liver transplantation. And for the use of URSO, the data are mixed. The European guidelines, the EASL guidelines, the traffic light is yellow, and at least in Europe you are still allowed to drive into the intersection when the traffic light is yellow. In the US, I would say the traffic light is red according to AASLD recommendations. And the future certainly are new compounds such as Nor-ursodeoxycholic receptor ligands, such as FXR, who may be able to target both the gut microbiota, and also the underlying inflammatory and carcinogenesis driving the disease. And there may be room for new biologicals targeting the gut, which so far have been neglected. And with this, I want to thank for your attention. Thank you very much.
Our next speaker, Dr. Arun Sanyal, will be discussing novel therapeutics for the management of NASH. Arun?
Thank you, Henry. So we move from cholestatic liver diseases to a common problem, and that is non-alcoholic fatty liver disease. When thinking about this condition, it's useful to consider it in two parts. First, the metabolic and the inflammatory components, which are the engine that drive disease progression towards cirrhosis, and the fibrosis, that is the readout of these metabolic inflammatory disturbances. So when you put it all together, there is a spectrum of histology that you see, where at the bottom you see individuals with fatty liver, and then as you move up this pyramid, eventually you get steatohepatitis, some fibrosis, advanced fibrosis, and then cirrhosis, and eventually people who have liver-related outcomes due to the cirrhosis. Now, one of the issues with this condition is that when you're at the base of this pyramid, the natural history is quite variable and thus less predictable, because some people spontaneously improve while others worsen. But we clearly know that there are significant numbers of people who worsen, because in all of our clinics, we are seeing patients with more advanced disease. And there are national data now that we are seeing more and more people with advanced NASH and cirrhosis presenting for liver transplantation. Whereas in the more advanced diseases, because the disease is more predictable, it is easier to identify who is at risk and connect the development of therapeutics to improvement in outcomes. So the challenge is that at the base, where you have a lot of your patients, there is uncertainty in predicting who has disease progression and thus identifying who most will benefit from therapeutics. Now you could argue, well, we don't have much by way of therapeutics. Why bother worrying about this? Just tell them to diet and exercise, because this is a condition closely linked to diabetes and obesity. The problem is people in the obesity world have been working on diet and exercise for the last 50 years. And if you look at the national statistics, it tells us how well that's worked. And the majority of patients cannot engage in this and maintain that. So if you can maintain it, great, but most people can't. So we need therapeutics. And then the challenge then becomes to identify the population that really will benefit from these therapeutics, particularly so because all of the treatments that are currently available have some limitations. So you have to weigh the benefits of therapy against the risks of therapy. So there's some guidance in this regard at this meeting. There is an abstract by Beth Brunt, which actually focuses down on this and tells us that if you take individuals who have early stage disease, if they have multiple features of the metabolic syndrome, they have progressive weight gain, they have persistent elevation of their ALTs, and that enriches the population of patients who are going to progress to bridging fibrosis or cirrhosis within a 3 to 4 year time frame. And if you biopsy those patients, particularly if they have ballooning with Mallory bodies and have more severe inflammation, particularly in the portal tracts, those are the parameters that allow us to identify who will progress. Now, when you think about treatments, the ideal treatment should be one that is rational. So it is worthwhile to spend a minute to think about what the potential targets for treatment might be in patients with fatty liver disease. We know that insulin resistance is the key driver of this condition. And so if you start with insulin resistance up here, what that does is it increases lipolysis in adipose tissues. The result of that is an increase in free fatty acids, and this is seen by the adipose tissue, which becomes inflamed and releases cytokines, which are pro-inflammatory. The pancreas responds by increasing insulin secretion, and all of these combine to flood the liver, which responds by packing these extra fatty acids in the form of steatosis. But there is widespread metabolic dysregulation, which results in injury to the endoplasmic reticulum, production of oxidative stress, mitochondrial injury that lead to inflammation, apoptosis, all of which converge on stellate cell activation with the final readout of fibrosis. So if you believe this, two logical targets are to turn the tap off at the very top using an insulin sensitizer or attacking a key downstream target such as oxidative stress, and these are the two targets that have been most studied so far. So this slide summarizes the existing literature regarding vitamin E and antioxidant. Now, other antioxidants have also been looked at, but the results are extremely mixed, and we really cannot make any recommendations about them. But if you focus on these studies, all of the studies where histology was looked at actually show improvement in histology. And at least two of these studies were large enough that we can make some definitive statements about the role of vitamin E in terms of improving liver-related histology. Now, if you look at glitazones, there have now been about 7 randomized trials, of which 4 were placebo-controlled. Primary outcome was histologic improvement in these studies, and it shows that you improve steatosis, you improve inflammation, you improve ballooning, and actually, in this meta-analysis, we found there was, when you combine all the data, you even have a signature for improved fibrosis. But there are problems with both of these treatments, as I'll show you. If you compare them side by side, we have data with large numbers of patients from both. With pioglitazone, and in fact it's a class effect, you get continuous weight gain while you're on therapy. In the PIVENS trial, which was the large trial, that was about, the median weight gain was about 8 pounds. And you don't lose this weight when you stop therapy. So that's a problem for a disease which is associated with weight gain. In addition, although it improves insulin resistance, another class effect is an increased risk of fractures, particularly in older women. You get fluid retention and sodium retention, and in those who might have a marginal cardiac function, it may precipitate congestive heart failure. On the other hand, with also more recently, as you know, there's an increased risk of bladder cancer with pioglitazone. On the other hand, with vitamin E, there is a concern based on a meta-analysis that was performed about 10 years ago that there may be a small but significant increase in all-cause mortality. But this meta-analysis, I will point out, was focused on studies where vitamin E was used as a tonic just to prolong life, for no apparent reason. And it clearly doesn't do that, and you get an increase in mortality. So this is why it is very important to use this concept of competing risks, where you only use a drug with significant risks if the competing risk from the disease is substantially higher. So neither treatment is particularly, they have some benefits, but they also have significant limitations. Also, the generalizability of vitamin E still remains to be established. And more recently, there's also been a study showing a 1%, but a significant 1% increase in risk of prostate cancer in men over 65 years of age. So that is the current status of where things stand. But what else can we do about this? So there are a lot of interest because of the limitations of our existing treatments for looking at newer therapies. There has been a paucity of therapeutic development in NASH compared to, say, hepatitis C. But I think this is changing. And in fact, even at this meeting, if you go around, you'll see a growing number of people getting involved in development of drugs around NASH. And recently, FDA had a major workshop trying to provide guidance to companies who are developing therapeutics for NASH. So some of the drugs that are currently being looked at include nothing that is currently at a pivotal trial stage, but if you look at phase 2b studies, pentoxifylline, fish oil, obeticholic acid, GFT505, SAMI, and other drugs over here. These are some of the drugs that are currently in phase 2b trials. So let's walk through these and see where we stand with them. Pentoxifylline has been studied in small investigator-initiated trials. One of the issues is that the number of patients in these trials are really small. We're talking about a disease that affects 3-4% of the population. And so really the problem is that even though these studies look very promising in that there is a improved histological improvement in patients on pentoxifylline compared to those on placebo, this really needs to be validated in a larger cohort of patients. What is particularly encouraging, though, about pentoxifylline is that multiple features of the fatty liver disease, such as fat, lobular inflammation, and ballooning, all seem to move in the right direction. So we need more data. But at this point, given that there are already 3 small trials out there, for those who do not respond to vitamin E, or if you're concerned about the risk profile of vitamin E, certainly this is an option. What about fish oil? Fish oil, as we know, particularly the N3 fish oils, have anti-inflammatory effects. They reduce lipid synthesis. They also improve insulin sensitivity. So a lot of theoretical reasons why they should work. In this study from Italy, they actually improved liver enzymes compared to controls. But at this meeting this year, there is a late-breaking abstract about a phase 2b study with over 240 patients who received an ethyl eicosapentaenoic acid, which is a synthetic N3 polyunsaturated fatty acid. And unfortunately, although it improved triglycerides, which you would expect it to do, it did not have any impact on liver histology. So it is also important to start taking some of these things that do not work off the table. Now, a lot of interest now in bile acids. One of the major findings over the last 10 years in liver-related biology has been the role of bile acids as an integrator between nutrient intake and the body's metabolic response. Because every time you eat and you have enterohepatic circulation of bile acids, the bile acids run around the body and tell all the cells, nutrition is coming, and so you can reset your metabolic machinery accordingly. So obeticholic acid is a derivative of a primary normal bile acid, chenodeoxycholic acid, but by adding this ethyl group, it increases the affinity for FXR substantially. Now, there are many reasons why FXR activation may be beneficial in NASH. First of all, we know through this SREBP1 pathway that you would reduce triglyceride synthesis. On the other hand, through this PPAR-alpha media FXR pathway, you might have increased fatty acid oxidation, so less synthesis, more oxidation, and then from a peripheral perspective, due to increased lipoprotein lipase activity, you might expect increased triglyceride clearance. Also, importantly, FXR increases SRB1. This is a receptor that gets rid of cholesterol that is being sucked from the arteries by high-density lipoproteins and actually gets rid of it through bile. So this is an important concept. So it actually affects a number of lipid pathways, and FXR in animal models has also been shown to improve insulin sensitivity. So this led to a small phase 2A proof of concept study, which was recently published. And this is a 3-arm dose-ranging study where it looked at 25 milligrams and 50 milligrams of obeticholic acid, compared it to placebo, in patients who had suspected fatty liver disease and had type 2 diabetes, suspected fatty liver disease by ultrasound and elevated liver enzyme, and exclusion of other common liver diseases. And in these patients, we did what was called a euglycemic clamp with high dose or low dose insulin. And as we go through the data, I'll explain how that works. So first of all, when we gave the drug, there was enrichment of the biliary pool with obeticholic acid, indicating that people were actually taking the drug. Also, if you look at the endogenous bile acid production, what we see is that when patients who were taking the drug actually had a decrease in bile acid production over the 6-week duration, indicating that yes, it was actually working like an FXR agonist. That's exactly what you would expect. Now, when you look at what it did to insulin resistance, the way we measured this is with something called the glucose disposal rate. Now, one of the main functions of insulin is to move glucose from the extracellular to the intracellular compartment. So the more sensitive you are to insulin, you need a lot of glucose to maintain normal blood sugars if you're infusing insulin at a steady state. So in insulin clamp, you infuse insulin so you have steady concentrations of insulin in the blood. At the same time, you start giving more and more glucose till you have a constant blood glucose level in blood. So when everything is in equilibrium, the amount of glucose you infuse per unit time is the amount of glucose being transported from the extracellular to the intracellular compartment, a measure of insulin sensitivity. So the more sensitive you are, the higher the glucose amount that you have to infuse. So then you can see over here that obeticholic acid actually produced an increase in insulin sensitivity over the course of the study. And at high dose insulin, which shuts down endogenous glucose production in the liver, you still saw the same effect. So essentially indicating that it had both peripheral and overall improvement in insulin resistance. At the same time, there was a stepwise decrease in body weight in these patients over the 6-week course of the study. When you look at the liver enzymes, what you see is that here's the green line, which is the placebo ALTs. In contrast, if you look at the intermediate dose, the ALT decreased. Interestingly, at high dose, it really looked pretty similar to what you saw with the placebo. And here are the data for AST, much less of a signal than with ALT. If you look at the lipids, what we see here, again, is that the triglycerides declined mainly with the high dose over here. As you would expect, the HDL declined. Now, whether that means a worsening of cardiovascular risk is very much an open question, because we think, at least based on theory, that this could very much be because of increased clearance and thus increased reverse cholesterol transport, which theoretically, again, should be a good thing. But I think this needs to be clarified further. And here are the data for total cholesterol, not much change. And here is LDL. And this is something that further needs more clarification, because you see over here there was an increase in the LDL. If you look at non-invasive markers of fibrosis, such as the ELF score, we do see, at least with the intermediate dose, some reduction. But again, I think we need to have more data over longer periods of time. If you look at the side effects, the most common side effect, constipation at high dose, and then some headaches, and then pruritus. Now, none of these were really serious adverse events and really did not require discontinuation of therapy. So these have now led to a larger study with 280 patients that has completed recruitment, and we hope to present these data next year. There are other drugs also in the pipeline. There is a phase 2b study which is well on its way to completing enrollment, and this is a PPAR-alpha delta agonist called GFT505. And this drug improves hepatic insulin resistance, decreases triglycerides, LDL cholesterol, decreases liver enzymes, and interestingly, does not induce PPAR genes in skeletal muscle, so this is a liver-specific effect. Now, moving finally to those with advanced fibrosis, the goal here is, of course, to reduce liver-related outcomes. And here you not only have to attack the engine, but also the readout, the fibrosis. And we are rapidly moving to a stage where we hope we can use non-invasive methods to really address this issue of fibrosis and find biomarkers that will tell us that you're reducing mortality risk. It is very encouraging to see this data where the NAFL fibrosis score, which is a non-invasive score, actually was closely linked to mortality in the enhanced cohort. Whether it is sensitive to change, I think now remains to be demonstrated. There are ongoing phase 2b studies attacking collagen, particularly collagen cross-linking by lysyl oxidase and by attacking it with the anti-lysyl oxidase antibody. And I think this is very potentially exciting because theoretically raises the possibility of reversing cirrhosis in a therapeutic manner, in a directed therapeutic manner for the first time in patients with NASH. So in conclusion, drug therapy of NASH must be provided to those with documented and established NASH with activity and some fibrosis, especially if multiple features of the metabolic syndrome and elevated ALT are present. I didn't show you data for metformin because it was negative and was restricted for time, but there are data that metformin does not impact liver histology, and while it's a great diabetes drug, it doesn't work for NASH. Glitazones have beneficial effects, but also have significant side effects. Vitamin E works and improves histology, but the generalizability has not been established, and the long-term safety, I think there are still some open questions, which is why before you select anybody for therapy, you have to consider competing risks. Several new agents are under study and appear to be promising, but I think hopefully in the next year or two, we will know how well they work. I thank you for your attention.
So what did we hear? I think in PBC, our approach is changing. We're more carefully predicting efficacy of treatment, assessing response in a careful and measured way, and I think the future holds individualization of therapy and risk assessment of the patient. Bile acids are no longer just detergents, but they are important regulators in homeostatic mechanisms and really offer us some opportunity for therapy in the future. In PSC, I think help is on the way. Would that be a message? There are multiple receptors that are operative in this syndrome and offer therapeutic alternatives, and the concept of the bicarbonate umbrella seems to be important in protecting the biliary system. In NAFLD, there's significant pathology, a significant burden to the population, but current therapy exists, and the use of bile acids, whether that holds an increasing promise, I think, for the future. So I'd like to thank my co-faculty for bringing this all to our attention. We do have some time for questions, and I'd like to start off with a question to Dr. Jones. Why biologics in non-response in PBC and not corticosteroids?
I think this is a great question because I've asked it myself. That doesn't make it a great question. I mean, I think it is a great question. So if you think there is an immunological component in some people to non-response, then why complicate it by going down the biologicals route? And of course, in practice, that's what we do. We re-evaluate patients who are non-responders, particularly in the young group. We look at their IgG levels, and we frequently biopsy them. And in people with a very inflammatory biopsy with evidence of interface hepatitis, we actually treat them with corticosteroids. So that's what we do in practice. And a small percentage of people will respond, and a larger group won't. So we were talking before the beginning of the session about many of the therapies have been tried in PBC. If you were to re-explore those in the context of response and non-response, would they be efficacious? The honest reason why people are doing trials of biologicals is because companies are interested in sponsoring trials of biologicals and nobody's interested in doing a trial of corticosteroids. So it actually is a very good question, and it's what we do in practice.
Thank you. Dr. Sanyal, pentoxifylline, for how long during a trial, and are these agents ready for real-world use?
Pentoxifylline has been around for a long time, so it's relatively safe. It's not very expensive. It can cause some nausea, and at least in one of the studies there was a significant dropout because of nausea. The dose is 400 milligrams 3 times a day, I think, if I remember correctly. It really doesn't address the root cause of the problem. So all of these drugs for NASH, I think, if once you commit somebody to therapy, if they improve, the chances are if you stop the drug at some point, they will all relapse and go back to where they start from, unless they have lost weight and they have now completely turned their life around. I'm not sure. I think we really, are not ready to make a general recommendation about pentoxifylline simply because the studies that have been done are so small. They are at best pilot studies. And what we really need is a study with a couple of hundred patients that answers very definitively yes or no. As you know, there's something called type 1 error, which is in these small studies, you're likely to find, things that appear to be significant when they really are not. And they're much more likely to get published if you see a positive finding. So there are all kinds of problems over there. And for a disease that affects so many people in the general population, I'm a little uncomfortable running out and saying, based on a couple of trials with 25 patients, that we're ready for prime time.
Thank you. Dr. Trauner, before the studies showing harm in PSC, treated with high-dose urso, there were encouraging data on higher dose urso for some patients with PBC. Do you ever use high-dose urso for PBC anymore?
The answer is no. Actually, the data show that increasing the dose in PBC does not increase the efficacy, so you cannot turn non-responders into responders. Having said that, however, the high dose, in contrast to PSC, the high dose in PBC, also in other diseases such as fatty liver disease, did not produce the side effects which we saw in PSC. So there seems to be something specific about ursotoxicity and the high dose with PSC, and that may be linked to metabolism by the gut microbiota and stuff like that. But there is no efficacy of high dose urso in PBC either.
Dr. Jones, you happy with that? Dr. Jones, how do you treat fatigue in your daily practice in PBC patients?
Have we got another hour or so? So I think this is an area of huge interest, and it's a big problem area. And I think that the quick answer to it is that there is no single magical therapy. It is an approach to it that is very important. And we have a protocol which we call TRACE to train people to do it. The T and R is treat the treatable. So fatigue in PBC is associated with inflammation. It's associated with hypothyroidism, with anemia, all of which are conditions that are associated with PBC. So the first thing you do is look for things that might otherwise be there in patients associated with PBC that give you fatigue. The A is ameliorate. We know that you get a lot of sleep disturbance with it. You get a lot of autonomic dysfunction with it. And both of those are amenable to therapy. So look at sleep and look at dizziness when people stand up. Simple things like giving them fluid replacement. C is cope. Tell people that how to cope with fatigue, and they have to own the problem. Don't you take on the burden for the fatigue. Patients have got to learn to live their lives so that we give them coping strategies. Simple things. Fatigue is worse at the end of the day, and it's better first thing in the morning. And so get people to have appointments that are important first thing in the morning. So you can actually make a big difference with that. And then the final thing is E, which is empathize. Don't feel sorry for people, but the fatigue is very real, and so help them to cope with it. And the final thing we have on our training thing is don't fail before you start. If you tut and cluck and say, we all get tired, I've been working all weekend, what do you expect? You'll get absolutely nowhere. So it's a real problem. You've got to work with people. Single biggest tip, apart from things like thyroid disease, treat the itch first. So there is nothing like nighttime itch to make fatigue worse the next day. And so the most effective therapy for fatigue in PBC is really effective treatment of itch. We would never embark on clinical trials. We have a number of trials running. Actually, itch is a contraindication to those trials because you must treat the itch first. And there's some very exciting trials coming along with novel agents for itch in PBC, and I think they will have a big overall benefit. We are interested in Rituximab as a treatment for itch. We've got 35 people into a phase 2 trial targeting fatigue, and that looks quite interesting. We've also got some data on exercise intervention to change the physiology. But there is no magic solution at the moment. It is an approach that is supportive and lets people live with their life.
Thank you. I think I'm going to take the opportunity on the question on fatigue to wrap this up for the evening. Thank you.